Dr. Varenga, and good morning, colleagues. It's always a pleasure to join you. I'm trying to move my slide. Oh, okay. So that's the outline. I've got a little bit of internet problem, so you might, if you don't hear me, please shout. I'm gonna talk about the placental tumors and the value of ultrasound examination. I'm gonna share one of that I've recently managed. Given we've heard from the previous speakers that the placenta in our ultrasound medicine fraternity. However, if one look at the attention paid to placenta, some of the conditions that we found in the placenta, and I've listened to the previous speakers, have got serious implications for the pregnancy, and has want to pay attention to the placenta. So let me introduce you to Ms. T, just to bring this into context. She was a 30-year-old, grafter 4 para 1, with a history of 2 previous first trimester miscarriages, the cause of which was not established. She had normal booking bloods. However, she was B negative. And the good thing is that Combs, at the time of the examination, which was 20 weeks, was also negative. As I've mentioned, she had had 2 previous miscarriages after a successful NVD attempt. So for all purposes, except for her blood group, she looks like a low-risk patient. She was then referred to us 20 weeks for anatomy assessment. And during the scan, we picked up a 2-centimeter hyperechoic mass. And on applying the Doppler was negative. Then the question really was, what was going on with this patient in terms of what we're dealing with? Was it a bleed? The problem was the location of this mass, which was in the substance of the placenta. But it doesn't mean that it might not happen. Was it chorioangioma possible? Some studies suggest that you should be able to see some evidence of Doppler uptake on it. So we were stuck with a patient that we really don't know, a small mass. Baby looks at, as far as ultrasound is concerned, no abnormalities. So we decided, well, we don't know what it is. It could be any of those. And so the patient was canceled, and the attending obstetrician was quite comfortable to do the follow-up. The rest of the pregnancy was uneventful. However, she presented at 7 weeks in labor. And you can see the CTG there. I remember I was attending a meeting in Cape Town, so I got that CTG from an obstetrician asking, what should I do? You know, very difficult because you can't remember some of these patients we have seen later on. And the decision was, well, we don't know what is going on, but the CTG is a little bit worrying, so please go ahead and do the Caesar. Caesar was done for fetal distress. A female baby, 2.7 kg with Apgar 3, 5, and 6 was delivered, severely acidotic, and was then subsequently taken to NICU. Interestingly, the HB on this fetus, the neonate was fine and did well and was discharged after 2 weeks of staying in ICU. And I think this illustrates the importance, which I've just mentioned, that some of those things looks very innocuous at face value, but the consequences for the pregnancy can be dire, as was the case with Miss T. Unfortunately, with her, the outcome was great. So it's very important when one look at, when you're performing your ultrasound assessment, to spend some time looking at the placenta. And I think Dr. Verenga spoke about this. And I'm just gonna say, for the purpose of placental tumors, he's spoken about the function, spoken about a basic assessment. What I just want to remind everybody is that be systematic. You can imagine if you see that 2-centimeter tumor and you haven't, paid some attention to it, you're gonna miss it completely. And when something wrong happens during pregnancy, you have no clue as to what is going on. And for us in fetal medicine, often when you get somebody referred to you and you give an advice, you do a scan and make assessment and give some advice in the management, most of the obstetrician will never bother to really look at anything later on, because the belief is that this baby was seen by the fetal medicine specialist. So therefore, if they say everything is fine, therefore there is nothing that is wrong with this pregnancy. So they will continue without really paying attention to what is going on. So look at the location it was discussed. And of course, if you've got a placenta previa, you need to make sure that you exclude inversion. But what I want you to look at really is look at the size of the placenta. And again, Dr. Verenga spoke about do a visual estimation of the size. People who scanned a lot will be able to say this placenta doesn't look normal in terms of size. And Dr. Verenga also again was kind enough to say that if you can see the placenta, the whole of the placenta on the screen, then you need to ask, is it a small placenta or is there something going on there? And the opposite is true. Look at the placenta, if it looks big, then you really need to start wondering what is going on. And again, you can measure the thickness. Most of the data suggest 2 to 4 centimeters next to the central point of the cord insertion. Most importantly, look at the morphology. How does the placenta look like? Again, I always say this like driving. If you drive very often, it becomes automatic. So if you have seen enough placenta, it's pattern cognition. You will see when something doesn't look okay. Look at for additional lobes. And of course, might find some tumors. He spoke about the cord insertion, which I think is spotted. And of course, Dopplers is important, not only for fetal growth, but even for assessment of these masses when you see them. So if you really look at the most common tumors, so these tumors probably affect about 1% of pregnancy. You must say that that's very little, but I can tell you for this year, that was my second chorioangioma that I've seen. Maybe you can say I was lucky to see that. And I've every few years, I come across some form of tumors in practice. So when you look at the classification, you've got primary, your primary is trophoblastic and non-trophoblastic. I don't think I need to speak about the trophoblastic. We all know about the gestational trophoblastic disease, your partial and complete moles. And of course, don't forget your intraplacental choriocarcinoma, because this can have serious consequences for both the mother and the fetus. The most common non-trophoblastics are chorioangioma, the teratomas, and the placental mesenchymal defect, or PMD. And of course, the lymphomas, the maternal secondary is usually advanced maternal disease. And I'm going to talk about it a little bit later. But most commonly, you need to worry about your lymphomas as well as your primary lung and breast cancers, which the pathologist has touched on. And it was quite nice to see the figures that he mentioned. For the fetal, the tumors that usually goes to the placenta is most commonly, most often than not, is your neuroblastoma. And that will probably be followed by rhabdomyosarcoma in some cases. But usually, if you come across anything, so neuroblastoma. The problem with the fetal or placental carcinomas and tumors is that these are extremely rare. And really, if you look at the literature, all that you come across is case report isolated from different places. So it's quite difficult to get a comprehensive review of the extent of this condition and how they affect the pregnancies. I'm not going to talk about this because I think nobody really misses this, especially your complete moles. We're all very familiar with this. Patient comes in with symptoms. Either they're going to have high blood pressure, early onset preeclampsia, signs of hypothyroidism, and we do apply. Sometimes we get hyperthyroid, and the beta ECG gives us a clue. And of course, the ultrasound gives us, the modern ultrasound is not like the old one where people talk about snowstorm appearance. I think here you can see the cyst, and you'll probably see that this placenta doesn't look okay. You sometimes get a mimica, which usually will be hydropic placenta after a miscarriage. But usually in those cases, the beta ECG will be low, so it'll be easy to distinguish between the two. Your partial mole, usually you'll see the same thing with a fetus. And of course, we all know that these carry bad prognosis. And therefore, when you see that, you need to be active in terms of management. And usually these fetuses will have IUGR. When we look at the trophoblastic intraplacental choriocarcinoma, and I'm going to just talk about this briefly because this is quite important. This is a rare variant of choriocarcinoma spectrum. Majority of the cases are very small and asymptomatic and are easily missed. And usually those ones that are very small, less than a centimeter, they usually don't do anything. They get picked up at placenta examination for one reason or the other. However, there are some that might present with metastatic disease, and this can go to the fetus or even maternal. In fact, the literature and the case report that are there suggest that if for some reason you suspect during your ultrasound examination and intrapartum, natally that this patient has got a choriocarcinoma, you need to follow this patient, even if nothing has happened during the pregnancy, the way you will follow somebody with a gestational trophoblastic disease. The challenge with this is this concept of elevated beta ECG, and this always has been an issue. How high should the beta ECG be for one to suspect that this is choriocarcinoma? Should be in the millions, should be in the 100,000, and again, in the lack of systematic reviews and robust data, it's very difficult to advise one when should they be worried. And the clinical assessment is very important. Context is key. If you get a beta ECG that is very high and ultrasonography, you suspect that with a very high uptake of your Dopplers, you really need to put some attention on monitoring and even post-delivery follow-up. What is challenging with these tumors is that it presents a spectrum of disease, might look exactly like the rest of the placenta. So in other words, as echoic. Sometimes you see echoic masses and you don't even know what you're dealing with. And sometimes it may present with cystic changes. And again, it really about you must have a high level of suspicion. And when in doubt, rather err on the side of follow-up and making sure that you don't miss the persistence of the disease, because it can have serious consequences for the mother. The complications of abnormal placenta, so one will expect things like abruptio, your fetal anemia because of the shunting, and sometimes because of the bleed. And of course, this patient tends to present with preterm delivery. However, what is good about this is 60% of the cases will result in live birth with no serious consequences for the fetus. I've already touched on the diagnosis and management as I was talking through the slide. So then you have the one that I've just given you an example, the case report of the non-trophoblastic group, and the most common being the chorioangioma. It's really a benign proliferation of the vascular channel, which is supported by the chronic stroma. There seems to be some reports that this is common in pregnant women who live in areas of high altitude, and there's been a question whether this is due to hypoxia. Unfortunately, we really cannot say because we don't have enough data to make that conclusion. What is quite notable in this is that if the tumor is very small, so in other ways, is if it's less than 5 centimeters, most of these are clinically significant. And in the case that I've given you, it was less than 2 centimeters or plus minus 2 centimeters at the time that we saw this. And unfortunately, we have been seeing this patient later, but it's very clear that at the time of delivery, that tumor has grown, but it didn't. We don't have the values to say how big was it, because even the specimen that I showed you was basically a tumor that was taken piecemeal, so we're really not able to measure. And I'm not sure whether they struggled with extracting the placenta or they decided to open to see what was going on, and hence they provided us with that picture. The complication for this tumor, again, is fetal anemia, thrombocytopenia because of platelet stripping. They can present with abruptio, preterm labor, and of course, on ultrasound, you can see an echogenic mass, and you can see in that one hypoechoic in that picture. And if you are lucky enough, some studies actually suggest case report that you might actually not have high vascular intake early on in the early first and second trimester, late first and second trimester. And I suspect that is the reason why we can't demonstrate color Doppler at 20 weeks. The teratomas, again, are the extremely rare, but probably the most second commonest non-trophoblastic tumors. And the teratomas is exactly how we know them. Sometimes very difficult to distinguish whether they're coming from the fetus or they've got their origin from the placenta. However, as you know about the teratomas in gynecology, they're all the same. You've got your benign, mature, or benign cystic teratoma, and malignant immature teratoma, which tend to carry a bad prognosis. The ultrasound features, you can have a mixed picture of mixed solid and cystic masses, and that picture sometimes can resemble a chorioangioma, and it might be very difficult sometimes to know what we're dealing with. 10% of those are completely cystic, and some can be lobulated. What is quite helpful with this is when you found calcification, which is found in about 40%. And if you see that, that's sort of like distinguish teratomas from the others. And usually these tumors have got a favorable prognosis, and usually follow-up is adequate. The third non-trophoblastic placental tumor is your placental mesenchymal defect, or PMD. This is probably extremely rare. It's a vascular tumor. Usually, these mothers will present with huge placenta, which is often multicystic. If you really look closer, you'll find that they've got high vascular uptake, and on pathology specimen, they've got thick tortuous vessels. It's very important when you suspect this to look at the fetal liver, because they tend to present with liver cyst and even vascular malformation on the fetus itself. And so you need to do a proper evaluation of the fetal organ, including the brain. Been also been associated with Beckwith-Wiedemann syndrome. The challenge with that, it's got variable outcome. And again, what I've said initially is that the challenge with this is all that we have is case report. And personally, I haven't come across one, so I don't really have experience. And that would be interesting if any of you, even Prof. Nick, have had any experience in this with this condition. The complication, of course, is IUGR, and like the rest of the placental tumors, preterm labor is always a problem. Then it leaves me with one slide, I think that my second last, to just mention in passing that let's not forget about metastatic cancer. And I'm saying this because just yesterday I saw a patient who was referred to us with Beckett lymphoma at about 20 weeks. And we had a discussion with my colleagues about the issues about management. Fortunately, she has already been started on treatment. And of course, one needs to be very careful and put some effort in terms of monitoring these pregnancies. However, if one look at the literature, cancers in pregnancy, it's probably account to 1 in 1,000. So it's not really that bad. So meaning that in an institution like, for example, Bara, where they do about 20,000 deliveries, you're probably going to get about 20 patients per annum. With us, probably looking at about 8 to 9 patients presenting with cancers. So it's very important to pay attention to this. What is very clear now in the literature, and I've just mentioned the European societies, that the treatment should be similar to non-pregnant women. In the past few years where I work, we've lost a lot of patients, especially with breast cancers, because our medical oncologists were not comfortable in treating patients. And from time to time, we have to have a meeting with them to discuss these issues, that we cannot compromise a mother because of the pregnancy. Of course, we know that if we give chemo during the first 12 weeks, and maybe there might be a room to defer if there's still an opportunity, because of the risk of 10 to 20% risk of major congenital anomalies. But that should really be balanced against the risk to the mother. What we need to consider is that there are cancers which will metastasize to the placenta and the fetus. And in particular, you're looking at melanoma and primary pulmonary cancers. And to some extent, your gastric lymphomas, your gastric cancers, your lymphomas in that order. And this was a review by Kazak et al., which was published in 2022. So I think the key message that we really need to consider is that these tumors are extremely rare. And majority of people will not see them in their lifetime, unless if they are working in a referral unit. However, it's very important that even when these tumors are rare, be systematic in terms of the way you look at the placenta. Pay attention the way you pay attention to looking at fetal morphology. And should you have a suspicion that something is happening in the placenta and you're not sure, seek an opinion from somebody who might be an expert in the field, or probably a colleague, and so that we don't miss those tumors that might have severe consequences to the mother. Thank you very much for the opportunity.